Howdy! Today we're going to walk through the physician office examination room, the space where most of the hands on patient care in an outpatient setting actually happens. Our goal is for you to understand three connected things. First, how the room is laid out and what features and equipment you'll find in it. Second, why keeping that room clean and disinfected is so important and how that cleaning is actually done between patients. Third, how to choose and correctly use personal protective equipment, often called PPE. As a medical assistant, you will spend a large part of your day in this room. You will room patients, take vital signs, set up for procedures, assist the provider, and then turn the room over for the next patient. Knowing the room well makes you faster, safer, and more confident. It also protects your patients and protects you. Throughout this lecture, I want you to think like a professional who owns this space. Every choice about where things go, how surfaces are cleaned, and what protective equipment you reach for is a patient safety decision. So let's get started. Here are the learning outcomes for this lecture. By the end, you should be able to do five things. One, identify the standard layout, zones, and the core features of a typical exam room so you can picture the space and move through it efficiently. Two, describe the equipment, the furnishings, and the safety fixtures you find there and explain why each one is present. Three, explain why routine sanitization and disinfection matters. In other words, why we clean it all and how it protects both patients and you as a worker. Four, outline the actual process of cleaning and disinfecting surfaces between patients. We will talk about cleaning before disinfecting, about contact time, and about high touch surfaces that matter the most. Five, select the right PPE for the task in front of you based on what you expect to be exposed to, and then put it on and take it off in the correct order. Keep these five outcomes in mind. They are exactly the kinds of competencies you will be expected to demonstrate in the office and on certification exams. Before we look at individual pieces of equipment, let's frame what the exam room is for. This is the primary clinical workspace in an office. The vast majority of outpatient care happens right here. Everything from taking a history and vital signs to assisting with minor procedures and patient education. Notice that a good exam room is trying to satisfy four goals at the same time. It must be comfortable and private for the patient. It must be efficient for the provider so care moves quickly. And it must support infection control so no one leaves sicker than they were when they arrived. Those goals sometimes compete, and the layout is the compromise that serves all four. The room is also organized to match a predictable workflow. Patients are greeted, roomed, assessed, examined, educated, and then discharged. When supplies and equipment sit where that workflow needs them, care flows smoothly. Finally, never underestimate first impressions. Clean, organized, fully stocked room tells the patient that this is a careful, professional practice and it builds trust before the provider even walks in. As the medical assistant, you own that impression. Think of yourself as the owner of this space. Every choice you make about placement, cleanliness, and stocking is a patient safety decision. Although no two offices are identical, most exam rooms follow the same basic logic that helps to picture the room as a set of zones. Look at this top down view. The patient and exam zone is the heart of the room. The exam table usually has its head against a wall and is often set into a corner, but pulled out far enough that the provider can still reach the patient from both long sides, and so the foot of the table has clear space, which matters for many exams. Along one wall is the provider and charting zone. This is where you find the rolling stool, the computer or electronic health record workstation, and very importantly, the hand washing sink. Placing the sink where the provider and the assistant naturally work makes hand hygiene easy, and easy hand hygiene gets done more often. A clean supply zone holds the cabinets and counters. The key idea is that clean, stocked supplies stay covered and organized, separated from anything that might soil them. Near the entrance is the seating and entry zone, with the door, guest chairs, family members, and hooks for belongings. Notice the sharps and biohazard containers placed close to where they are used at the point of care. Good layout is not decoration. It shortens the steps between a task and the supplies or safety device you need, and the efficiency directly supports both speed and safety. Let's now inventory the equipment you will use every day. Start with the exam table. Many tables have stirrups for certain exams, built-in drawers for supplies, and a roll of paper that you change between every patient to give each person a clean surface. The hand washing sink is your most important infection control tool in the room. It should be stocked with soap and paper towels, and most rooms also have alcohol-based hand rub for quick hand hygiene when hands are not visibly soiled. You will use a rolling stool that adjusts in height and a positionable exam light so the provider can see clearly. For vital signs, the room holds a blood pressure cuff, often called a sphygmomanometer, a thermometer, a pulse oximeter that measures oxygen saturation, and a scale that should be calibrated so weights are accurate. Mounted on the wall, you will usually find a diagnostic unit with an otoscope for the ears and an ophthalmoscope for the eyes. Finally, the computer or electronic health record workstation lets the provider chart, place orders, and pull up education for the patient right at the point of care. Your job is to keep all of this stocked, charged, calibrated, and ready so that when the provider enters, nothing slows down the visit. Beyond the obvious equipment, the room contains furnishings and safety fixtures that quietly do a great deal of infection control work. Cabinets and counters are not just storage. They keep clean supplies covered, labeled, and physically separated from anything soiled, which protects those supplies from contamination. The sharps container is one of the most important safety devices in the room. It is puncture resistant, mounted close to where needles are used, and it should be replaced when it is about 3/4 full, never overfilled because overfilling causes needle stick injuries. The biohazard waste container, lined with a red bag and labeled, receives regulated waste, meaning items contaminated with blood or other potentially infectious materials. That is a different stream from ordinary trash. Gowns, drapes, and table paper give the patient privacy and create a clean barrier that you change for each patient. Personal protective equipment or PPE should be stocked right in the room so that protection is always within arm's reach. And finally, there is a clearly marked stream for general, non regulated waste. Knowing which container is which is a skill you will use constantly because putting waste in the wrong stream is both a safety problem and a cost problem. Why, oh, why do we spend so much time and effort learning about and cleaning a room that may look perfectly clean already? The answer is that environmental surfaces become reservoirs for microorganisms. According to the Centers for Disease Control and Prevention, or CDC, germs move from contaminated surfaces to patients mainly through hand contact with these surfaces. So, cleaning and disinfecting, paired with good hand hygiene, breaks that route of transfer. Let us put names to the ideas. A contaminated surface that can carry pathogens is called a fomite. Fomites are everywhere in a clinical space. When pathogens reach a vulnerable patient, the result can be a healthcare associated infection. These infections are a genuine threat to patient safety. They slow recovery, lengthen treatment, and raise costs, and some are caused by organisms that are hard to treat. Not all surfaces carry equal risk. High-touch surfaces such as the exam table, doorknobs, light switches, and counters are touched many times an hour, so they deserve the most attention. Finally, remember the volume of an exam room. A single room may serve many patients in a single day. Each turnover is a chance to either pass an organism along or stop it. This is why a reliable cleaning routine between patients is not optional. It's a core to safe care. These three words, cleaning, sanitizing, and disinfecting, are often used loosely, but they mean different things, and this difference matters. Cleaning physically removes dirt, debris, and organic material using a detergent and water. It's also the first step because you cannot disinfect over soil. Organic material like blood or mucus shields germs from the chemical, so a surface must be clean before disinfecting can work. Sanitizing reduces the number of microorganisms to a safe level as defined by public health standards. It lowers germ counts, but it does not necessarily kill every pathogen present. Disinfecting uses chemicals registered with the EPA or Environmental Protection Agency to destroy most pathogens on a hard surface. In patient care areas, disinfecting is what we rely on for high touch and soiled surfaces. There is a useful framework here called the Spalding classification. It sorts items by infection risk into critical, semi-critical, and non-critical. Exam room surfaces that contact only intact skin, like the exam table or counter, are non-critical items. Non-critical surfaces are cleaned and then disinfected according to the level of risk. Items that enter sterile tissues, by contrast, are critical and must be sterilized, but that is handled differently and is beyond a routine room turnover. For our purposes, remember the order: clean first, then disinfect. Let's now talk about the practical heart of this lecture: how an exam room is actually disinfected between patients. Picture this as a repeatable 5-step routine. Step 1, start with hand hygiene and put on the right personal protective equipment. Gloves are the baseline, and you add a gown or eye protection if you expect splashing or heavy soiling. Step 2, clean first. Remove any visible soil, discard the used table paper, and empty waste. Remember, you can't disinfect a dirty surface effectively. Step 3, apply an EPA registered disinfectant to the high touch surfaces, the exam table, any rails, the counters, doorknobs, and equipment that hands touch. Step 4, and this is the step people skip: respect the contact time, sometimes called dwell time or wet time. The label tells you how long the surface must stay visibly wet for the product to kill the organisms it claims to kill. If the label says 4 minutes, wiping it dry after 30 seconds means you did not disinfect, you just moved the germs around. Step 5, let surfaces air dry. Replace the table paper, restock supplies, then remove your PPE and perform hand hygiene again. 2 cautions that come straight from CDC guidance: always follow the product label and your facility policy, and never double dip, meaning never reuse a cloth on a clean area after a dirty one, or return a used cloth into the solution container, because that can spread contamination. PPE makes the most sense when you understand the idea behind it, which is standard precautions. The principle is simple but really powerful. You treat every patient's blood and body fluids, other than sweat, as if they are potentially infectious, no matter what the diagnosis is or who the patient appears to be. You do not have to guess who is infectious because you assume the risk is always present and you protect accordingly. From that mindset comes three practical points. First, you choose PPE based on the anticipated exposure of the task in front of you. Ask yourself, for this task, do I expect contact with blood or body fluids, or a splash or a spray? Your answer tells you what to wear. You do not select based on the patient's diagnosis. Second, this is not just good practice, it's law. Under the Occupational Safety and Health Administration's bloodborne pathogen standard, your employer must provide appropriate PPE at no cost to you. If it is missing, that is a problem you can and should raise. Third, keep PPE in perspective. It is the last line of defense. It works together with hand hygiene and safe work practices like careful sharps handling. PPE never replaces washing your hands. It adds a barrier on top of good aseptic technique. Here are the four main categories of PPE you will use and the cue for when each one is appropriate. Gloves are the workhorse. You wear them for any anticipated contact with blood, body fluids, mucous membranes, or non-intact skin, and when handling contaminated items or surfaces. For routine rooming, you will use clean, non-sterile exam gloves. Gowns protect your clothing and skin. You wear a gown when a task could splash or spray or soil what you are wearing, for example, during certain procedures or cleanups. Masks and respirators protect your nose and mouth. A surgical mask guards against splashes, sprays, and respiratory droplets. A fitted respirator, such as an N95, is used when airborne protection is required. Eye and face protection, meaning goggles or a face shield, is added whenever a splash or spray could reach your eyes. A face shield protects the whole face, while goggles focus on the eyes. Tie it together with one selection rule. Match the level of protection to the expected splash, spray, or contact. The more exposure you anticipate, the more barriers you add. A blood draw with no expected splashing may need only gloves, while irrigating a wound that could spray calls for gloves, a gown, a mask, and eye protection. You are constantly making that judgment, and it should become second nature. If you are ever in doubt as to the type of PPE you should be using, check with your office's exposure control plan for guidance. Putting PPE on and taking it off in the right order is not just being fussy. The sequence is designed to keep contamination away from your skin and mucous membranes. When you don, that is, when you put the PPE on, you move from clean to contaminated. The CDC sequence is gown first, then mask or respirator, then goggles or face shield, and gloves last. Gloves go on last so they can cover the cuffs of the gown and stay the cleanest item until you actually touch the patient. When you doff or take the PPE off, you remove the most contaminated items first. The sequence is gloves first because the outside of your gloves is the dirtiest surface in the room. Then goggles or face shield, then the gown, and finally the mask or respirator. The mask comes off last after you have left the patient area and you avoid touching the front of it. Two habits tie it together. Perform hand hygiene before you don and immediately after you doff. And remove everything slowly and deliberately, peeling items away from yourself so you do not flick or smear contamination onto your skin, clothing, or face. If you forget everything else, remember this: gloves on last, gloves off first. That single rule prevents a large share of self-contamination. Let's pull this whole lecture together into 5 takeaways. First, the exam room is organized into zones: the patient zone, the provider zone, the clean supplies zone, and the entry and seating area. That organization exists to balance 4 goals at once: comfort, privacy, efficiency, and infection control. Second, the core features include the exam table, the hand washing sink, your vital signs and diagnostic tools, and the safety fixtures such as the sharps container and the biohazard waste container. Know what each item is for. Third, for cleaning, the order is clean first, then disinfect. Use an EPA registered product, focus your effort on high touch surfaces, and honor the full contact time so the product can actually do its work. Fourth, for PPE, select based on the exposure you anticipate and follow the sequence. Gloves go on last when donning and come off first when doffing. Fifth, and most important, consistent infection control is the habit that protects your patients, your coworkers, and you. It's the quiet, repetitive work, and it's exactly what makes you a professional. Master these routines now, and they will serve you far into your entire career. Here are the sources behind today's lecture. Feel free to look through them a little more deeply if you have more questions about today's lecture.